Okay, now we're going to talk about overdoses. So anytime you have an overdose, we always will rely on poison control. They're amazing. They will walk us through step by step. They give us advice whether to transport, where to transport. They're the specialists. When you transport someone to the emergency room, they're calling poison control. So there's no reason we wouldn't take care or we wouldn't take advantage of the same expertise. So the number's the same, so make sure that's in the cell phones, your personal cell phone. They do an amazing job. So this just talks in general about overdose, but we'll talk specifically about each individual. So beta blocker, if you knew the name, you knew it was a beta blocker, the key to that overdose is the glucagon. Typically, they're going to be bradycardic. That's why the pacing and the Versed is in there. Now, the poison control will give you the dosing. It could realistically be up to 4 or 5 milligrams. So if the truck doesn't have that, depending on where you are, whether you call another truck or just transport, you would have to discuss that with poison control. Because typically none of us have 4 milligrams of glucagon. Very expensive drug, so I don't anticipate us carrying 4 on each unit just for this, because it's not that common. The calcium channel blocker, we already talked about it, to do with when we administer it, same idea. Your treatment would be the calcium chloride, fluid, and then again, if appropriate, pacing. Cocaine overdose, when we deal with these patients, they could have chest pain. We're given the Versed for the hyperactivity. It talks about the agitated patient. You notice we're using the ketamine for this. There's an IM dose and an IV dose. When we talk about the excited delirium, there is no IV dose. Why would that be? They're crazy. They're aggressive. There's no way we're expecting you to start an IV when the person's aggressive. So in that protocol, you'll see it's only IM. This one, there's an IV dose because it's reasonable that maybe you would be able to start an IV. In either case, there is a chance that the patient would have chest pain, particularly in cocaine. It can cause vasoconstriction. That's why you would follow the chest pain protocol, because that is not uncommon. Narcotic overdose, we left the range for the Narcan. So you can still give the 2 milligrams IM or give it incrementally. However, we've been doing it. We purposely left that window open. For the tricyclic overdose, the bicarb would be the key. Poison control could walk us through that, but it has to do with the pH level of the drug. When you become acidotic, the drug's free. We give bicarb, and that binds the drug. So it has to do with the bicarb changing the pH is why we're giving that. But again, poison control would walk us through if you weren't 100% familiar with what the drug was. Okay, now we're going to talk about chemical control. So when we talk about the physical restraints, as always, we got to be careful of how we're restraining our patients. We would never hogtie. We want to be able to justify what we did with the patients and utilize BSO when appropriate. If we're talking about chemical restraints, our primary drug would be our ketamine. So this is what we were talking about earlier, that we only have an IM dose. So you notice there's a dose range. On the next screen, we'll discuss a little bit why you might consider giving 200 milligrams. So whatever dose you decided to give, we wrote in there that you can repeat the dose of ketamine. So if your first dose didn't work, we want to make sure our crews are safe. You can administer a second dose. We're not concerned with ketamine of knocking out the respiratory drive. If we overshoot the dose a little bit and the patient's out, we can manage that. So we want to make sure the crews are safe. So we wrote it in so that you're very comfortable of repeating the dose if appropriate. So if the patient is older, they have head injury, a smaller patient, or you believe they have a benzo or alcohol on board, is when you would consider giving the 200 milligrams. But again, if it didn't work, you can repeat that dose. This patient, you would reasonably believe they would be acidotic, so again, why the bicarb and the cooling is all in there. Any questions on, yes, sir?
More Benadryl for that?
For excited delirium?
Yeah.
No. No. Now, the hypersalivation you see occasionally, and just like in organophosphate, the atropine would dry that up. But we wouldn't just prophylactically give Benadryl with this. Do you want to discuss that specifically?
Just very briefly, if you give the ketamine to the patient, you're not going to affect the respiratory drive. But the patient can have what's called an emergence phenomenon. So just tell the staff at the emergency department that you've given ketamine, you have not given a benzodiazepine. If you give those two together, ketamine and benzo, you can knock out their respiratory drive. So we've decided to just give one drug, ketamine, and let the people in the emergency department know that the patient can go through an emergency scenario. Okay?
But if you had success with Benadryl in the past, you're not allowed to use that anymore, is that what you're saying? Benadryl.
Benadryl.
Just, you mean just as a sedative? What Dr. Farrell was just talking about is one reason why some departments don't use it for pain for all people. So there are some issues when they come out of ketamine, and there's discussion on if we give it through an infusion or IV push. So that's another example that we may change slightly how we're administering the ketamine in certain circumstances. Okay, so pain management. If we had to say, what do we give for pain management? We're giving fentanyl. So the dose changed a little bit, but it's pretty consistent. So we would give our fentanyl, we can repeat it once, our max of 200 mics. If the patient's still in significant pain, that's when we consider going to our ketamine. But the ketamine we're giving for pain is very different than the dosing we're giving for the excited delirium. For pain, we're giving a dose of 25 milligrams. So right now, the way we're saying to give it is you're going to dilute your entire bottle of ketamine, all 5 mLs, into a 50 ml bag. So now I'm going to end up with a 10 milligram per ml concentration. And what's my dose I just said? 25 milligrams. So for my first dose, how many mLs am I going to pull out of my bag? Right, only 2.5 mLs. I can repeat it twice if they're still in pain. So the most I'm going to pull out of my bag is 7.5 mLs. That's it. The rest of the bag I'm going to dispose of. So just be aware, we're not dripping the whole bag into the patient. So very different. And again, we'll go over that. If you're using the IO, you notice we now have added lidocaine back into the protocol. Starting the IO is not the part that's the most painful for the patient. It's when we start administering fluids through it. So the 40 milligrams of lidocaine will numb the site and make it more bearable for the patient. So that's why we're adding the lidocaine back into the protocol. Okay, same idea with the pediatrics. The dose of fentanyl doesn't change. We use our pediatric tool to help us, and then ketamine's an option. Okay, this section for the advanced airway. As of today, we're not going to be getting RSI. We may use ketamine down the road to facilitate innovation. The few cases we had in the last couple of years, the problem was the patient had trismus. So ketamine wouldn't fix that anyway. In those cases, we were able to bag through that, and we had good success. So in a while, we haven't had a case where we'd have to use that RSI. So until we can train up a little bit, we're not going to use it right now. But we're keeping the protocol in for education and informational, and also so you have an idea of if we do call for the helicopter, this might be one reason why we call for the helicopter, and then you'd have an idea of what they would be doing to help us. Okay, environmental emergencies. We already said the decompression sickness, the key to that for us is transporting the patient to a hospital with a helipad. The drowning, so the patient survived. We would definitely have a high suspicion if there was fluid in the lungs. Doesn't mean they're gonna have fluid just because the patient was drowning, but if you suspected they were, make sure you're considering using your CPAPs. Okay, heat emergency, we deal with every summer. We're good at that, so unless there's a specific question, I'm gonna go through these slides a little bit quicker. Okay, bites and stings, we have the Xyrem spray. The Xyrem spray is working great. So if you don't have them on your truck, we have plenty in the pharmacy. Let us know and we'll make sure everyone has the Xyrem spray. But these protocols have stayed pretty consistent. Okay, carbon monoxide, again, the hospital with the helipad, and then they'll decide where the chamber is if it's appropriate. Who has the cyano kits? The battalions, right. So that's why we wrote in there, contact the battalion. Battalion 6-3 and Battalion 2-4 or 103 now has those kits. We each have one kit. Okay, say again?
Oh, but only one?
Only, well, we have two. Typically, one will work, maybe use another. If we need more than that, our neighboring cities, we know that we can call each other.
We've gotten away from that being primarily for us on the fire. It's just.
Yeah, if you suspect it, yeah. So some cities and some hospitals don't have any. So it's not uncommon for the hospitals to get a case where they think it's a cyanide case, and they'll actually call us to transport it to the hospital. Again, they're inexpensive kits. All right, so we're going to take a break, and then we'll start talking about trauma. Okay. Okay, so now we're going to talk about trauma. The guidelines for trauma, they have changed a little bit. When we see the parameters for triaging, those are the same triage tools that we've been using. So START and Jumpstart for the kids. So get familiar with those. Those are the same. What has changed is the cut sheet. So you'll notice they've added a few things for the level 2, and they've added blunt abdominal trauma for the pediatric. So what happens is the trauma committees meet, and if there are some injuries that are becoming common, and it would help including them on our sheet so we don't miss injuries, they update these sheets. That's how that works. So this is our summary sheet that we use on scene that we're used to. So just be aware that the latest one does have some subtle changes to it. The back sheets go into more detail explaining what the cut sheet means. So this information should coincide with the information on the cut sheet. There was a question on whether aspirin qualified as an antiplatelet. So hopefully this makes it clear. Should we consider aspirin an antiplatelet in terms of calling a trauma alert? No. So this makes it very clear. We do not include aspirin. So traumatic arrest, if you're not going to work someone, we're going to use this criteria. So if they're apneic, they're pulseless with asystole and fixed dilated pupils. So we added in injuries incompatible with life. So we're right by the train tracks. If someone stepped in front of the train and the head flew over the building and we got there quick enough and we put the limb leads on, could that person be in PEA? Yes. Would you work that? Obviously not. So that's why we added in the injuries incompatible with life, to just make sure we're answering as many questions, because that actual scenario we dealt with at one point. When you look at the penetrating injuries, it talks about how to control bleeding, clotting agents. We're gonna make sure all the units have the same clotting agents, and we're gonna get bags together so we have a unified system and materials to be able to deal with this. But when it's at a junctional trauma, meaning at your underarm, something that you couldn't use a tourniquet or put direct pressure, that's when it would be appropriate to use these things. The one change for us, if you have penetrating trauma, before you call the person, They want us to do bilateral chest decompression to rule out a tension pneumothorax. If you get a pulse return, we work the patient. If you don't, then you could say, okay, we're not going to work the patient. So that's a change for us as well. Burn injuries, same idea with the burn injuries. You may have seen some earlier versions of the protocol that didn't have burn gel. We are still using burn gels. We like burn gels, so we added them back in. So just to make it clear, we cleaned up the language a little bit. All right, this chapter, we try to take out all the questions. So do we have to use a backboard when we're transporting a patient with back pain? No. So we made it very clear, a backboard is not required. So when we use stabilization or cervical stabilization, we use the collar, and we're going to be getting the new X collars, which training's going to do with us very shortly. So we put the collar on. We can use a backboard or a scoop stretcher if we're using it to lift or move the patient to the stretcher. When the patient's on the stretcher, the backboard or scoop stretcher is to be removed. Is that clear? What we're trying to do is make it so you're very comfortable not using the backboards. So does that mean you can never use the backboard? No. The intent is to try to make you comfortable under the normal circumstances not using it. So if you're at sample and third and you use the backboard and you think you're going to use it to transfer the patient, you can leave them on it. That's not what we're talking about. But as a general rule, the backboard is not benefiting. In fact, we're pretty sure that using a backboard actually is worse for the patient. So when we can, we're actually going to go to scoop stretchers. Probably a better option. We do have to keep a couple of backboards for helicopter use. So we will have some, but we're going to go to scoop stretchers hopefully sooner than later. So the idea behind this was to make everyone feel comfortable. So the other day we had someone get hit by a vehicle and they were using the backboard as a huge splint for the patient. That's not what this is talking about. That's fine. Okay, any questions on that? Good. Head injuries talks about hyperventilating the patient, lowering the CO2. That's something we're familiar with. Hopefully will help with potential swelling. Eye injuries, we kept tetracaine. We're going to add 1 to 2 drops PRN. Some people aren't familiar with tetracaine. It's not a flush. You would just put 1 or 2 drops to numb the eye. So we're going to add some language in there to make sure it's clear. So chest trauma, we already talked about the needle decompression. Okay, so unless there's a question. Abdominal trauma. Okay, pelvic fractures. The key to pelvic, yes?
It says on this here, helmets to be removed on all patients, that motorcycle, football.
Okay, let's go back. What page was that,
That's
Larry?
new, I think. 111.
Yeah. So helmets should be removed. Doesn't say shall. So if you feel comfortable removing the helmet, you can remove the helmet and you would want to have access. If there's an airway issue, definitely remove the helmet. If for some reason you don't feel comfortable, you don't have the right tools, you think it'll be detrimental to the patient, then don't remove the helmet, as long as you're able to assess the patient and manage the airway if appropriate.
So we're
Okay?
not considering a helmet anymore. Like before, it was basically it kept a stable spine in some cases.
Yeah, if you decide in your professional opinion that patient's better off leaving it, it doesn't say you have to. Should, that language is specific because it allows for better assessment, but if you deem that it's better for the patient to leave it on, you can leave it on.
The new,
Yes, sir.
The new X collars hold the head and the shoulders. They do not touch the neck. So these old C collars that old people are complaining about, feeling choking sensation with the collar wrapped around the neck, that won't exist anymore. The X collars have a large area in the front in case you have to do cricothyroidotomy or something. But these are a great improvement on C-collars. So we'll get the training done as soon as possible. You better use those. Okay, any questions on that? Okay, good.
Okay, where were we before Larry?
Just.
Hip fracture.
117.
Hip fractures, okay. So hip fractures, the key is to try to stabilize the hip, minimize any bleeding. So some of the agencies are using something called a T-pod. Right now, we're just using a sheet. We may adopt something else, but the idea is to stabilize the hip. Scoop stretchers and a sheet work very well. Femur, we're actually pretty good. We've seen a couple cases. If there's hip involvement, you may not want to use the splint, but we can talk about that when we do the training with the collars and everything. Okay, this talks about tourniquets, stop the bleeding. There's a whole presentation we're going to do sooner than later, so we're going to move over this unless someone has a specific question. Okay, trauma and pregnancy. The key was where you're going to go. We already answered those questions, so we'd refer back to that section. Trauma resuscitation. So if you have someone who's bleeding out, we now will have the option of calling the helicopter for blood. So we now know that whole blood is the best option for the patient. They will be carrying whole blood. Sooner than later, we may start carrying plasma, but right now we're not, so we're still going to be doing our saline and transporting to the hospital.
So if we call BSO out for blood, then are we relinquishing transport to them?
Probably, but they'll go over that when they come talk to us. If we want to call them merely for the blood, they're willing to do that too.
And then we transport ourselves?
Yep, so we'll have to ask all those questions when they come out.
I
But
think with the blood itself, that they would want to, because of the fact they're supplying us, it's almost just like supplying with a drug.
yeah, I'm guessing they're going to want to take the patient, because when they administer the blood, they actually use a specialized pump, now that you're saying that, and they have warmers and stuff, so I'm sure they would either come with us if that was more appropriate, or we'd turn the patient over to them, yeah. Okay, same idea, just the fluid. So neurogenic shock, so the patient has an injury, below that level, the body's not able to vasoconstrict, so the end result is the hypotension. So again, we're using our fluid and our push dose epi. Okay. Okay, this we left in there again for informational. So if we did call them for the blood products, we at least have an idea of what we would expect them to be doing. But we are not carrying blood anytime soon. Okay, OB. These did not change except for the eclampsia, so I'll go through these slides slowly. If someone has a specific question, we'll talk about it. Okay, ectopic. So eclampsia. So what's the difference between preeclampsia and eclampsia?
Blood pressure.
The seizure more specifically, but both might have significant hypertension. So if the patient has the hypertension, the altered mental status, the headaches, visual disturbance, so basically they're symptomatic, we're going to treat them. So if we're treating them, how much MAG are we giving them? We said it's always 2 grams IV, but we're going to give 4, but the other 2 we're going to give IM. So we're going to try that and see how that works.
We still treating postpartum 6 weeks?
So can someone be eclamptic postpartum, meaning after they gave birth? Absolutely. Up to 6 weeks. So absolutely could happen. Yep.
Wait, so we're giving our initial 4 in a bag, and then we're giving the second dose?
So
tonight?
what we're trying to do is make it easier for people to remember. So the MAG infusion, no matter what protocol you use, would always be 2 grams. Because eclampsia, 4 grams is the desired goal, we're going to give another 2 IM at the same time. So you would hang the drip and give them 2 grams IM. Okay, no questions, we'll keep going. So normal delivery. When you look at this, this is NRP. This is a whole class in itself. So obviously we don't have time to go into this. We're gonna get specific training on this, but just be aware when you talk about the respiratory, whether you're gonna bag it revolves around a heart rate of 100. If you're gonna give compressions, it revolves around a heart rate of 60. And if you decide to give compressions, it's at a 3-to-1 ratio, ventilating 40 times a minute. So this is the proper way to do CPR or resuscitate a newborn. So this is NRP, and we'll do more training before we implement the protocols. Okay, cord, prolapse. All right, this last section, again, talks about the drug. So on page 10, it talked about this, and we have it back here so that if you're gonna go to the pediatric medication tool, it's here all in one spot. So it talks about the same drugs that we talked about on page 10. This is the pediatric medication tool. So just be aware, when you're using this tool, make sure you're using the right drug, the appropriate drug, and you realize the dose, but very important is the concentration. Right now, we have the same concentration of drugs that they're using on this tool. But with the drug shortages we've been experiencing periodically, you have to realize if we end up not having the right concentration, because this tool would not work. You'd have to adjust the doses accordingly. So just make sure, it's very important to realize what concentration you're using.
So the Versed, because I remember you mentioned that about the Versed.
Yeah, so,
concentration.
yep, so Versed, we're back on the same page.
Okay.
Yeah, the only one that currently we have an issue with is ketamine. This talks about 100 milligrams per milliliter, we have 50, but by the time we go live with this, we'll have the right one. Yep, so we should have no conflict to this protocol when we're ready. And be aware, certain drugs, it depends if you're diluting them or not. So a good example is Benadryl or diphenhydramine. One route we dilute, one route we do not. So make sure you identify which route you're going with. Okay? Same tool, but different medications. And this talks about the medications and the doses. So that's exactly what you were asking. This tells you exactly what concentrations that tool deals with. And again, these are the ones highlighting which ones need to be diluted. Okay, pit crew, we're very familiar with pit crew. The whole idea is everyone has a job, we work efficiently. Any questions on pit crew? This highlights the changes from the last version. This being very new for us, this isn't as appropriate for us as in just read it all, take your time, write down your questions, and if I can't answer it, we will definitely get an answer from Dr. Farrell. We want to make sure everyone's comfortable. The whole goal of this is to make a protocol that takes as much of the guesswork out of it as possible. So in the future, when we would have to go to committees to make changes, we can make the changes on this. So please give your suggestions, because we will take them into consideration. We can't change everything, but if it makes sense, we can very easily make the changes. All right, does anyone have any questions? Okay, that's the end of the changes. Thank you very much for coming, and we look forward to continuing the training soon. Thank you.